start, sir.
Okay. Good evening, everyone. I am Dr. Samir Patel, practicing gastroenterologist at Noble Institute of Gastroenterology, Ahmedabad. Actually, I am sorry because Dr. Yogesh Harwani currently cannot join. That's why I had to start the session. So today is the 20th clinic of our this series of lectures, and today's topic we have is endoscopic ultrasound guided pancreatic wall of necrosis drainage as well as necrosectomy. And with us today we have Dr. Sandeep Laktakia. I think he doesn't need any introduction, but sir is a senior faculty at Asian Institute of Gastroenterology, and he is a head of endoscopic ultrasound unit. And with us, we have chairperson Dr. Viral Shah. Sir is a senior consultant surgeon practicing in Ahmedabad, as well as for as a moderator to talk. We have Dr. Kunal Bharadwaj. He is a consultant gastroenterologist practicing in Ahmedabad at Gastro Plus unit. Now, I will give the speaker to Dr. Kunal Bharadwaj to start the session and to moderate the session.
Okay. Thank you, Samir. I think Samir has made my job easy. He has already introduced the clinic topic as well as the speakers. I think I will be delighted to moderate this session by my teacher and my mentor, Dr. Sandeep Laktakia. Sir, please start the presentation.
Good evening, everybody. Can you hear me?
Yes, sir. Yes, sir. You are audible.
Oh, okay.
Yes, sir.
Thank you, Kunal. Thank you, Samir, and thank you, Viral. COVID has made us do a lot of webinars, and there's a spate and there's increasing fatigue developing in people, both speakers as well as the audience. I'm not sure how many people would be joining today, but since we had promised, I think we will continue the promise. I'm sure Viral is laughing, and I'm sure he must be agreeing to what I am saying.
Yes, sir. Yes,
I really don't know how many people have hooked on today.
people eager to meet physically in the presence.
And most of the talks nowadays, same talks are being repeated or circulated by different speakers or same speakers in different forums. But nevertheless, I think we will do the formalities since we have already committed. Whosoever joins is fine, and we can take the question answers as we progress further. So you can see the slides there, Kunal?
Yes, sir. Yes, sir.
Yes, sir.
We
So
can
I
see.
will be speaking as suggested on EOS guided drainage of walled-off necrosis and necrosectomy as a completion of the entire thing. So in this set of lecture, I would be covering these two aspects, mainly drainage of the pancreatic fluid collection by a plastic or a metal stent, and follow-up of endoscopic necrosectomy if required in some. So coming to the first part first, before we do the drainage, all the patients would have some imaging with them, which can be in the form of MRI or ultrasound or a good CT, which tells us that the fluid collection is mature after the onset of acute pancreatitis. And unless it is mature, I think it's not wise to consider them for drainage, because risk of leakage and perforation are much higher if they're not mature. And as you can see on the image, this looks a very nice, juicy, very well-defined collection with very minimal debris, which is black in color. This one has a little more debris in it. And CT scan also is done by many. It can show the maturity, but the amount of debris is not so easy. So if same patient, if you have a CT as well as an EUS can tell you more accurately the debris. And then you try to correlate, if you see carefully after the CT has been done earlier, which we ignored that, but later we found the debris is still there. So these are several ways of defining the fluid collection and seeing the maturity. Having said that, there's a clear-cut differentiation now with Atlanta classification, the modified one, which says that the walled-off necrosis and pseudocyst are two different things. They can be evolution of worn into pseudocyst or decrease in amount of debris. and they're basically defined by the presence of debris. If the collection is pure liquid, it's called pseudocyst, as you can see this one on the left, and this one which is also right on the right panel. And I'll try to skip the video and go. Another thing that you can see and collect on imaging is whether they are one or more, or if it looks to be two on imaging, are they communicating at some point of time in some place? If they're communicating, then draining one is generally good enough and not trying to drain both. Plus, any extension in mediastinal or deeper inside into the mesentery or peritoneum is seen or not. Then vault of necrosis is fluid, as you can see on the right panel, which is black in color, along with this irregular whitish area, which is debris. So whenever this whitish area is seen, it's called debris, and any amount of debris will now make this fluid pancreatic fluid collection being called as a vault of necrosis. Plus, EUS gives an addition of looking at the interposing vessels apart from what's inside the content, and these interposing vessels can then be avoided at the time of drainage. So coming to indications of drainage as standard, whichever way we drain, by surgery, by percutaneous, or by endoscopic means. In endoscopy, it can be EUS or transmural by duodenoscope, which was being done about 15-20 years back, but now EUS has kind of taken over all this spectrum. Whichever collections are there and they're close to the GI tract, that is, they're close to stomach or esophagus or duodenum, can be drained through the EUS. But those collections which are far away, and paracolic gutters, then we have to use an alternate option of drainage, which could be percutaneous or surgery, depending on the seriousness or sickness of the patient and the accessibility. So these are the standard indications of drainage of any collection, whichever way we want, following an acute pancreatitis. That is, infection within the collection and the patient has pain and fever, or just pain itself. And if the collection is big and causing any outlet obstruction to the bile duct or the stomach or even the esophagus, plus failure to thrive. Some patients just do not improve when the collection is there. And anything of these symptoms are there, then we consider them for drainage. And I told you earlier, we can consider them for either of three methods, but endoscopy is generally preferred, and transmural drainage is considered when it is a bulging cyst, or there were no vessel on CT scan and the wall thickness on the CT scan was less than centimeter. Endoscopy, I mean, is by conventional duodenoscope or a forwarding endoscope, which was being done earlier, and there are now several randomized controlled trials which have said that EUS is a better way of draining than the endoscopic drainage. The advantage of EUS is not only you can drain all these collections, but also the ones which are not bulging in the GI lumen. And even if there are many vessels in the wall, you can find that small window of opportunity where there are no vessels, and then you can reach that area. Having said that, transpapillary drainage of collections is rarely done in the setting of acute pancreatitis. It's mainly in setting of chronic pancreatitis with side branch rupture or a main rupture, which has led to pseudocyst formation. And if these pseudocysts are small in size, then you can do transpapillary drainage. So our main aim of drainage today in a setting of acute pancreatitis is transmural by EUS is the way to go forward. I'll skip this. So what's the advantage of EUS guided drainage is that it improves the localization of the collection. That means that you can see the entire extent and where exactly is the point where I would like to enter. So you can visualize the collection and avoid any interposing vessels, as I said earlier, and select the thinnest point of entry. That makes the job a little easier, provided the scope is not in a very oblique fashion. It's a straight scope, and the thinnest point of entry is the best way to go inside. Plus, we should know that the collection that we are draining is actually from the stomach and not the esophagus, because then we have to fine tune our further procedure. If you do not realize that you have punctured through the esophagus, which can sometimes happen in a higher up collection which are near to the cardia, then your instrumentation has to be adjusted in such a way that you don't cause any mediastinal perforation or complications. The drawback of EUS guided drainage is only that if you want to place a thick stents, that is about 10 French or so, through the accessory channel, which is 3.7, compared to a duodenoscope, which is 4.2, then these 10 French stents go very snugly, especially if the scope is in a long position. So let's go to the steps. So this will be a little bit of technical talk as well, so that people would be interested and they can fine tune their skills if need arises. So the first step first is when you see any collection which is mature on conventional imaging, then you do an EOS and you reconfirm those findings. So here we can see a very nice mature collection. This is a debris inside, and rest of the thing is entirely fluid. So in this static image, I can say that if I make it into half, so this is less than half, almost 25%, and this frame looks to be debris. But this is a very dynamic thing. If you go from one corner of the cyst to the other corner of the collection, then it could actually be maybe about 10% or so, because it may not be on the other side. So first thing is interrogation, and then you puncture it. I'm sorry, why the video is not playing. Okay. Anyway, this is okay. And once you puncture inside, then you pass a guide wire after aspirating the fluid for analysis. And these are the several needles which are available for puncturing. Alternately, some people have also used a cystotome directly for puncturing, or a needle knife. Needle knife is a very dangerous instrument because it's very flexible and it doesn't go exactly in the same direction where you want it to be, and it can dissect the wall and cause perforation. The first one is preferred by Europeans, where they use this flexible cystotome 6 and a 10 French combination, where they first puncture with a 6 French without a guide wire, and then remove the 6 French inner cystotome, and then pass a guide wire, and then over that they pass the 10 French cystotome. Whichever way we enter, we first remove the stylet and aspirate the fluid and send for analysis. So these are the pros and cons of different instruments that we use. A 19 gauge needle that is preferred by most is very visible, good transfer of force from the handle to the tip. The difficulty is sometimes you have the tangential puncture, especially in a long scope position, and sometimes the wires can get sheared, but that's more in the pseudocyst, not that's mainly in the biliary drainage than in other things. Cystotome, it's a cautery is used for penetration. It's flexible, adjustable. You can adjust the angle, but the visibility is not so good, and sometimes direction can change, and that can cause problems. Having passed the access the collection, then you pass the guide wire, and the preferred guide wire is a long wire should be used, not the short wire system. So it should be at least 450 centimeters, the standard wires which are used. And my personal preference is to use one which has an angled tip. The reason being that if the cyst is not mature, we are not able to interrogate entirely, then a straight wire can sometimes go bang on and hit the opposite wall and go into the peritoneum. So in a mature cyst, either of the wire is good, but in a doubtfully mature cyst, use an angled wire, which will not hit with a great pressure on the opposite wall, and it will bounce off. Once you're inside the cyst, you make several coils. In a big collection, one coil is good enough, which goes the entire circumference of the collection. And in a smaller cyst, you can have 2 or 3 coils. And once you've made enough coils, then you withdraw the needle. And the next step now is that over this wire, we create a fistula between if the entry point is stomach, then it's a cystogastric fistula, or any other part of the GI tract, that is cystoenteric fistula. It can be esophagus, it can be stomach, it can be duodenum. And it can be either mechanically dilated or electrosurgically dilated. Mechanical, as the name suggests, you pass either of these instruments. It can be dilator or a small tapered stiff balloon, or a bougie or a cannula, tapered cannula. Electrosurgical instruments are very commonly used, and 6 French cystotome is a standard that we use very often in our unit. Needle knife can also be used, but again, the same risk happens here too, that it goes tangential to the direction of wire and it causes dissection. So in mechanical, it can be bougie or a balloon. Those each have their own pluses and minuses. And electrosurgical devices can be cystotome or needle knife. Cystotome is the best preferred device by most expert interventional endoscopists. So let's see how it is done. Oh, I don't know why it's happening. Maybe there are too many videos and the videos
So
are
maybe,
stopped.
so sorry to interrupt. You can go in the folder and then maybe.
Yeah, just give me a minute.
Yeah, sure, sir, sure.
Okay, just give me a minute here. Something which happened. I'm glad Yogesh joined back. I'll just go out of the Zoom and come back in a minute. Something which happened. Yogesh, can you see me?
Yes, sir. Yes, sir.
Yes,
We
sir.
can see you,
Just
sir.
a minute. I
Good evening, Dr. Viral, Dr. Kunal, and Dr. Samir.
Welcome, Yogesh.
Good evening, Yogesh.
So to all audience, good evening, sir. So to all audiences, please bear a moment. There is some technical error with the video. We'll join back soon. So please be online. It may take 2 to 3 minutes. So Kunal, to discuss something till sir is back. In your unit, what are the indications for drainage of a pseudocyst or a walled off pancreatic necrosis?
Yogesh, the absolute indication, if we see, then infected WON, that is the absolute indication for EUS guided drainage, EUS or any drainage of the walled off necrosis. Then other indications are if they are symptomatically, which cannot be managed with medication, like if there is an intractable pain because of the increase in the cyst size, or there is or any other cause because there is a hemorrhage or all, then you can do the drainage. If they are causing the obstructive symptoms, like if there is a head or body pancreatic WN which is compressing on the stomach or duodenum and causing gastric outlet obstruction, or if there is a biliary obstruction, then this should be drained.
What do you recommend? Earlier, there were criteria that more than 6 centimeters, more than 6 weeks. Do you still follow that criteria? Is size anyhow important in today's date?
Usually what happens, more than 6 centimeter, if that persists after 6 weeks, the conventional guidelines say they are very rarely to resolve. But the latest guideline, all they say, if it is, even if it is more than 6 weeks, they can usually resolve if there is no any other complication like infection, or if there is no debris, if it is not WON, then usually pseudocysts they resolve. Very rarely in case of acute pancreatitis that pseudocyst persist. The WN can persist for long, but pseudocysts they usually resolve in case of acute pancreatitis. In case of chronic pancreatitis, it is very difficult that they resolve because most of the time it is a pancreatic ductal leakage, and they are rarely resolved in case of CP. I think Dr. Viral.
So you are mute, sir. You are mute.
Yes, Kunal.
Viral sir, just want to ask question that now endoscopics are taking everything from surgeon. Do you think still there are some morphology that can still be better tackled with surgery rather than this EUS or any other endoscopic
particularly
measures?
in pseudocyst, I say when there is a lot of necrosis is there with the slough and everything, stent, endoscopic EUS guided stenting and drainage may sometimes encounter the obstruction of the stents with the tissues and necrosis. In that case, surgery may give you better results.
Okay.
Whenever there is fluid is very clear, little bit of necrosis, preferred approach is EUS guided. But when there is a lot of necrosis and the patient is not good, fever, persistent fever, and all that, clinically not good, straightway going for a surgery and a definitive treatment may help the patient earlier.
I feel it more depends on the amount of necrosis, because if
Yeah.
amount of necrosis is more, then endoscopically things can be performed, but it will need recurrent endoscopic interventions at weeks. And in our country, it may not be feasible to do it every 10 days because many patients are from periphery. Affordability is an issue. So what we follow is if more than 50% necrosis, directly goes to surgeon. If less than 50%, we can go ahead with endoscopic necrosis.
I think sir has joined.
Yes.
Okay.
Welcome, sir.
Do you see my screen now? Okay. Can you see my screen?
Yes, sir. Yes, sir. We can.
I'm sorry, I apologize. This folder is so heavy, and all these files are not in one folder. They're in different parts of the computer, so I had to switch off and switch on, and that took some time. So this is the first step of puncturing the collection, as you can see it here. You can see the needle all the way, and then you pass the guide wire inside, and then these are steps that I covered earlier, and moving forward. So this is the next step of once you have a guide wire secured inside 1 or 2 loops on the fluoroscopy, then you do create a fistula, which can be a mechanical with a bougie, cannula, or any of the stiff instruments. And once you create this fistula, then other instruments can then pass much easily. But most people don't prefer this mechanical, and cystotome is the most preferred device, I said earlier, which literally burns, and in a few seconds you're inside the collection. And once you have created the fistula, then you dilate with a balloon. And I'll go back to the previous slide again, because that's an important slide I'll share again. And then you dilate with a balloon, which can be 10 to 15 millimeters from the stomach. Or if you have gone through the esophagus, then about 4 to 6 millimeter is safe. And from the duodenum, 6 to 8 millimeter. So that's a dictum. And having dilated now, then you can pass a second guide wire inside if you plan to place 2 or 3 plastic stents. And now I'll go back to the previous slide. And how do you place multiple guide wires? And there are several devices. There are cannulas which have multiple channels. 2 or 3 wires can go inside to different channels. Or this is a double cannula wire. Loop wire, which is now withdrawn from by Cook, is another interesting wire. If you have passed the first wire straight, then you can pass this second wire over the first wire, and this can be easily done without any extra cannula with multiple holes. So if you have entered from the stomach 10 to 15 millimeters, esophagus 4 to 6, and duodenum 6 to 8. And if your intent is to place metal stent, which I'll cover later, then a small caliber balloon of 4 to 6 millimeters is good enough. So this is a small caliber balloon for placing a metal stent, but a larger stent, larger caliber is used if you want to place a plastic stent. So what is the size we generally prefer is if the pseudocyst is only there and not a one, then and it's sterile, then 10 to 12 millimeters from the stomach is good enough. But if it's infected, then you go a little big. Allow the infected material to come out in the stomach, provided it's the stomach the point of entry. But esophagus and duodenum don't overshoot the intended size. If it's a walled off necrosis, whether it's sterile or infected, then at least 15 millimeters should be done, because then you sometimes have to do necrosectomy at the later date. And then the final step of placing the stent. So you have first punctured, first step, and pass the guide wire. Second step is creating a fistula. Third step is dilating the tract with a balloon. And the last step is placing the stent. And plastic stents, which we generally place for pseudocysts or one with very less debris, then always place both the plastic stent, both the guide wires before, and then place one by one. Never try to place one stent over first wire and then to try to cannulate in that hole, because then you can dissect and cause more complication, and the procedure gets prolonged. The longer the procedure, more chances of complication. So never try to skip a step so that you can do it later. Always follow the same steps. This is an important slide I thought I will share with all of you, is which are we see differently. By EUS, we can see endoscopically, we can see fluoroscopically, and by EUS image. So all three images are available to us if you're doing under fluoroscopy. So inspection is done by EUS. Puncture is done purely by EUS. You don't require endoscopy and fluoroscopy. Guide wire, you can easily see under EUS, but fluoroscopy is needed to confirm whether it's kind of circled inside nicely along the circumference of the cyst. You don't require endoscopic view at that time. Creating a fistula, again, EUS is alone good enough, but you can require fluoroscopy to check whether you have crossed it or not. But sometimes the feel itself is good enough and you'll know that. Then next step of balloon dilatation, again, with EUS you would know, but fluoroscopy and endoscopy is sometimes required to reposition the balloon so that it's not entirely inside the collection. So half is inside the collection, half is in the GI lumen, and then it bridges well over it so that it doesn't move around. And then lastly, placing the stent, again, we use EUS as a first part, but more often we use fluoroscopy and endoscopy to see the exact placement of the correct positioning of the stent. Moving forward, the next step is most patients now recover after placing the stents. At least 3 out of 4 would recover, but 1 out of 4, that is 25%, may have some symptoms which have not resolved or new symptoms may come up. And that's where the role of endoscopic necrosectomy starts. So what does necrosectomy mean? That you take a forwarding endoscope, go through the hole which you have created now after further dilatation, and then go inside the cavity and now clean it up. And there are several instruments that can be used, which can be snare, basket, Roth basket, tripod, bipod, pentapod. So all those things are there by which you can catch these loose debris and try to take them out one by one. This is a very labor intensive procedure. So if you have placed upfront plastic stent, then it is not done at the same sitting of the first drainage of placing plastic stents. Symptoms are observed, and 3 or 4 days later after the index drainage, if the symptoms are persisting or have come up now, then you do this. So the tract now collapses a little bit, so you have to dilate again with 15 millimeter balloon at least, and take your scope inside beside the plastic stent. Don't take them out because that's your kind of lifeline by which you can enter beside it, and then keep doing it. So algorithm is that you place first 7 French stents. You can use a nasocystic tube also for irrigation purpose. Second session, you after debridement, you place again a stent extra if you want, or place a nasocystic tube for irrigation, external irrigation. So dilatation can be done up to 15 to 20 if aggressive people are there, but my personal preference is 15 or maximum 18 is what I have done. I never do 20. You go inside, inspect the cyst. If you see granulation tissue and some loose debris, the loose debris can be entangled in your snare, which is my preferred instrument for debridement. And once you feel that the entire area is having good, healthy granulation tissue, that is probably the end point. Sometimes you see debris is quite adherent to the back wall, and you try to nibble it out with various instruments, nothing comes out. In that situation, I would say not to do further. Just place a nasostic and irrigate with 100 ml of saline 8 hourly for next 3 or 4 days. Most of this adherent debris becomes loose with passage of time. If a person has infection and frank pus is there, which is also with adherent debris, then you can use hydrogen peroxide. So these sessions are done 2 or 3 days apart. Each time you'll have to dilate with a balloon because the opening closes back. And gradually you keep doing it. On an average, a patient which has significant debris takes 2 to 4 sessions, I would say. And that's where the role of these metal stents come. So if you have a collection which has significant debris, what is significant is debatable. Anything less than 10, I would say, is treated like a pseudocyst, but anything more than 30 is like significant. So between 10 and 30 is a gray area, which can do well with a plastic stent, but may not do very well with a plastic also. So that is the area where you have to take a call. And that's where these stents come very handy. These large carryable metal stents are dedicated and meant for these pancreatic fluid collection drainage. And there are 2 categories. Lamps, as we all know, Axios is a standard lamps. They're lumen opposing. Whereas the Nagi stent is not so lumen opposing. It's called biflange metal stent. And that's a difference. So they can migrate in and out if you try to do too much of wriggling inside, and the lumen of these stents are shorter or thinner. So how do you place Nagi stent? So first step remains the same. You puncture, then you pass the guide wire. Second step also remains the same. The third step of passing a cystotome remains the same. The fourth step of dilating a balloon remains the same, but only thing that use a smaller caliber balloon. We don't use a large caliber because if you do a say 15 millimeter dilatation, the fluid will gush out, and then when you're passing a metal stent, the cavity is either getting emptied or almost nearly empty. So you want only a little bit of fluid to come out, and your steps should move very fast. So then you follow with its Nagi stent and place it under, the inner part is placed under the US vision. Then you use a fluoroscopy for the inner part also. So inner end is US and fluoroscopy, and gastric end is by endoscopy and fluoroscopy together. And this would be the perfect position that you would like to have, about a centimeter jutting out in the stomach. If you see this kind of a uniform waist, which is half this side and half this side, that's perfect. That means the marker in the center has the thinnest point, which you can also sometimes see on EUS, which is something like a bow tie that we wear. And most walled off necrosis now actually improve just by placing this metal stent. And this we had published 3 years back, now actually 4 years, that our index drainage kind of patient got cured, 75% of patients got cured. But those who did not improve, we went step by step to different levels. This is a step up approach where we placed, did a cleaning of the stent which was clogged by the debris. That improved by about 5%. And if that did not help and the debris was adherent, then we placed a nasal tube and did irrigation. That further improved by another 8%. And finally, we did necrosectomy in a smaller percentage of patients. So overall, about 10% required necrosectomy. And at each level, we got incremental success. So that's how we approached. The other stent which is there, which I called is hot Axios, is selling like hotcakes nowadays. Expensive stent, but very efficient stent. With no time, you can drain the entire collection without fluoro as well. So it can be done as a bedside. You don't require fluoroscopy. Just EUS and endoscopic vision, you can do the entire things. It has a little steps marked on the assembly, which are a little complicated to understand first, but once you get used to it, then it becomes an intuitive way of delivering these stents. And these stents also expand with passage of time, or you can dilate at the time of placement. For Nagi also, it expands in 2 or 3 days time, but we don't dilate because the risk of migration is very high, whereas risk of migration with Axios is much lesser, and you can do it. Here you see this patient has a large amount of debris inside, almost nearing 50%. And these are the ones which may require necrosectomy. And that's why you need a more efficient stent, which is lumen opposing, where you can do a necrosectomy if required later on. So once you start seeing the black marker in the stomach, then you release the other end. And you see the pus coming out. Hot Nagi is trying to mimic what Axios is doing. So it has a cautery enhanced tip, which can burn its way in, just like Nagi. Although the transmission of force is not as efficient as Axios, but if the wall is thin, then you can actually do it similar to what is done with a Nagi stent. And just like hot Nagi, hot Spaxus is also available, which is a lumen opposing stent. So if cost is a constraint, then these stents can be used, either hot Spaxus or hot Nagi. But I believe a cold Nagi or a cold Spaxus does as good a job. Of 5 minutes extra if you spend, and if you can cut down the cost, which is a common concern in India, then it does a lot of good. But whichever stent we place, they're all very, very efficient. I said 75% of walled off necrosis disappear just by placing any metallic stent. It's only 1/4 required some kind of intervention later on. And this is how it looks like. And then you can pull out these stents by 3 to 4 weeks when the collection is gone. So further interventions, as I said earlier, required a step-up approach. This is the stent which is clogged by the debris, and you can very easily tease it out using any instrument. And I said earlier, my preferred instrument is a snare, which can just catch it gently and tease it out. Once you clean the cavity, you can clean the stent lumen, you can go inside and peep and see what is to be done further. If required, you can do at the same sitting. If the debris is adherent, I said earlier, or it is significant, then you place this nasocystic tube for external irrigation. And last step is to do necrosectomy through the Nagi stent into the cavity. So this is frank pus, patient is symptomatic, and then you can use an instrument either staying within the lumen of the stent or going inside totally and watching inside. It all depends on how capacious the cyst is, because they rapidly decrease in time. So advantage of these large caliber metal stents are they're easy to deploy and high technical successes now with experience gaining widely all over India. They are large diameter, at least 16 to 20 millimeters, and so efficient drainage is possible, and they're fully covered, so prevent any leak and perforation which can occur with plastic stents. They're self-expandable, so prevent any bleeding which can occur at the entry site. I will show some example later on. And the design is either biflange or saddle shape, which reduces the risk of migration. And re-intervention is also possible through these stents. So all these are major advantages, but there are some disadvantages also with all these stents. And what are those? Sometimes malpositions occur, especially in the beginning of career. It has occurred with all of us. And these can be tied over, but it is a challenge and unnecessary strain to the society, to the system that you're following or that unit. Bleeding from the vessels can occur later on. This has been reported both with majority with Axios, because it's a little firm stent, and as the cyst collapses, the back wall comes and rubs against it as the patient respires, and that can cause bleeding. Migrations also can occur spontaneously, which can, or it can add direct endoscopic necrosectomy. And sometimes they can be hindrance to endoscopic necrosectomy also, because they have flanges inside, and the debris can be on the sides of these flanges where your instruments cannot reach it. As it is, the cyst has collapsed from 10 centimeter to 5 centimeter, and in that the debris is around the walls of the collection of the stent, then you cannot reach it easily. So you have to take it out and then do necrosectomy. So which stent to use? I tried to answer it earlier. I'll re-emphasize. So plastic stent is good or preferred for patients which have pure pseudocyst or which have very less debris. Anything less than 10%, I think plastic is as good as a metal stent. Above 30%, metal is good. It is quite efficient and can drain off easily. The gray area is between 10 and 30%, and which is still kind of a debated area. I'll show one more example of necrosectomy now, which through the, this is now through the Nagi stent. Earlier we did the declogging of the stent, but here we have a large necroma. And again, I use my preferred instrument of snare. You can catch it. And if you get a good grip on a large necroma, it can come out in one go through the stent. But often, if it's a big necroma, it carries a stent also along with it. So this was a very large chunk which came out in one go after a few attempts at catching it. It is almost as good as surgical necrosectomy. So you can be lucky. But having placed a metal stent, one must remember that that job is not done there. You have to tell the patient that this has to be removed. It's a foreign body. Unlike a plastic which can be left indefinitely, metals have to be removed because of risk of complications. And generally by 3 to 4 weeks, we remove them off. We always prefer to do an imaging before removal, that is MRCP, to look at the ductal anatomy and place a plastic stent if there's a disconnected duct or the patient has any residual collection left behind. So this is one of the internally migrated stent. Although the cyst has resolved, but patient came much later, and you can peep from inside this stent that the wall is quite healthy, but we don't want to leave it because there will be deeper, there will be blood vessels, and this can cause future problems. This is still in time because you have an access to it, but gradually this gastric end of the stent keeps closing down, and sometimes it gets like a buried bumper. It can be totally covered inside and may not be visible, and that then surgery may be required. So the complications of drainage of one is that bleeding, perforation, infection, and air embolism. The last is almost gone now because everybody is using carbon dioxide. Infections, yes. Perforations have reduced drastically because these are fully covered stents. So if you have a perforation which has occurred time of drainage, you switch from plastic to metal. If your initial intent was plastic, switch to metal, and so goes for bleeding. So let me show you an example of a patient which was with very minimal debris. We had a plan of placing a plastic stent, but while doing the procedure, we realized that it's torrentially bleeding. You can see it here, and you put a Doppler, it's an arterial bleed. It's bleeding with a pulse rate. So we decided not to go ahead with plastic, but immediately switched to a NIG stent, and this is what we are placing. And when it expands, it causes tamponade to the vessel which had ruptured. So you can see the blood in the lumen, but it's stopped now. So we keep a plastic stent just for a prevention of any migration or occlusion by the debris inside. But the bleeding stopped, which was a major disaster which could have occurred in the same patient. Sometimes these stents can migrate inside, as you see it here, and you can salvage it by, if you have a opening visible or a plastic stent there which can guide you, then you can dilate this path with a balloon and then go inside the cavity using a forward wing endoscope. You see the pus coming out, you see the stent deep inside, but if you catch one of the edge of the stent and gently pull it out, it's a very soft stent. So if you feel NIG and Axios, NIG is a very soft stent, so it doesn't cause too much damage, and you can reposition it back. So that's the beauty of it, which is unlike Axios where repositioning is not very easy. So in the end, I would like to conclude by saying that metal stents are good for walled off necrosis with significant debris. Plastic stents are good for pseudocytes with minimal debris. Reintervention is only done in patients who have symptoms which are either persisting or have newly occurred, especially like persistent SIRS is going on. And reintervention can be in various forms, at cleaning the stent lumen, doing a lavage or DEN, or sometimes multi-gateway can be done, or even percutaneous. The extension more in a paracolic gutters you can reach by percutaneous routes. But remember to remove these metal stents early after a finite indwell time of 3 to 4 weeks. With that, I would like to sum up here by saying thank you very much for your kind attention. Any questions or comments?
Yes, sir. Yes, sir. So there will be a few questions, and so it was a very lucid presentation. So, sir, when we do a necrosectomy, sir, means in the second sitting, once we enter the cavity and remove chunks of debris, many times we encounter bleed from the cyst wall. Most of the time, these bleeds are self-controlled, but occasionally they may bleed more, which may lead to panic at this time. So what precautions can be taken, and if such bleed occurs, what can be done to stop this such kind of bleed?
That's a very valid point. So necrosectomy risk of, because the base is very raw. It's a healthy granulation tissue which is happening, but the vessels are round, and you touch with a snare or any instrument, bleed happens. It's generally a minor ooze, but sometimes you can see big vessels at the through traversing the cyst, which are splenic vessels, and they can bleed torrentially, either splenic vein or artery. So if you see any of those vessels, I would suggest not to use your instruments very close to them, especially all these forceps and snares can injure the vessel, and that is so use a water jet and do a blunt dissection with water jet. Do not be in a hurry to clean the entire cyst. You can come back another day, because a lot of cleaning happens naturally. The human body is kind of a defense mechanism. The acid goes in and cleans it up. So give it that time. Or if you feel the debris is too adherent, leave a nasocystic tube and keep irrigating. But if you see a vessel, don't use hydrogen peroxide, just saline is good enough.
Sir, do you recommend that PPIs or any anti-acid medications or H2 blockers should not be used when we place such stents?
Yes, so we avoid using any PPIs unless it's recommended for some other reason in that patient, because we want the acid to be there, and we believe this acid trickles inside and does some cleaning.
Yes. Sir, what is the amount of necrosis you decide that this should be handed over to a surgeon?
So If somebody has more than 50% debris to start off with, I would have a meeting with the surgeon and the patient together, and we tell the pros and cons of both the procedures. So cost, surgery, hospital stay versus. So if the patient is willing for a non-invasive, non-surgical method initially and willing to take a surgical option later, which can occur in, say, I would say 1 out of 4 with a patient with significant debris. So I would approach that way. But those who do not want a unclear path, I let them go to surgeon straight away who can do a better job than me.
Sir, if if there is a site, WN is treating toward the paracolic gutter, still we go for US guided drainage, or we should send it to surgeons?
That's a very good question, Kunal. I'm glad that you asked that. So there'll be that we divide cyst by in 3 ways. Some are central collections which are very close to the stomach. Some are peripheral collections which are paracolic and have no, they're not close to GI tract. And the third variety, third variety is are large ones which can be approached both percutaneously as well as by the endosonographically. So the first one goes to endoscopist. The pure paracolic go to radiologist, and the one which have both, like from center to the periphery, we tackle them together. So we do a combined drainage, and that's a very important thing. What is combined drainage? Combined drainage is where radiologist will place a percutaneous catheter, but they will keep it locked, and the patient will then come from the radiology room directly to endosono room. So there has to be good communication and frequency match so that it's done at the same time. Then we do an EUS guided drainage and let it drain. Once we have done, then we open the percutaneous drain open. So now we have, the patient has 2 gateways of drainage. One is in the stomach and one is paracolic. The purpose of this is that it becomes more efficient and it prevents a future external pancreatic fistula. I'm sure all of you must have seen this, that when you do percutaneous or a surgical drainage, they put a drain. Now the patient has become better, but he's hanging with a drain, which lasts for 1 month, 2 months, 6 months, or sometimes even a year or so, which we don't want it. This has also been shown in the Lancet trial where the surgery versus endoscopic treatment went. This was a major difference between the surgical versus endoscopic drainage, that we don't have an external pancreatic fistula. So if the endoscopist drains and leaves it, and then it comes to us on second day, by the time the fluid is already gone and we cannot see then that collection. So this frequency or synchronization between the radiologist and the endoscopist should be good.
Sir, you put NCT, that nasal cystic drainage tube, in all patients of WN drainage?
So another good question. So we don't, if there is frank pus and lot of debris seen on EUS at the time of drainage, then I would place at the index drainage itself a metal stent and a nasocystic tube. But if the patient has only debris and no fever, I will just leave like that, a metal stent, and the patient is always admitted. So we have a clinical follow-up on the patient. If he's doing well, in 3-4 days time and a CT screening shows that the collection is totally gone, then he goes home. But if he has symptoms that is not, or has not improved, or has worsened, then we do a quick CT screening followed by endoscopy. At this endoscopy, we'll often find the stent either clogged or blocked by the debris, which we will remove and then place a nasocystic also, because there will be more debris inside the cavity, which we have now observed from the stomach going inside the cavity, and then we irrigate it.
Sir, that H2O2, hydrogen peroxide, everybody uses the different formulation of it. What is the AIG protocol? What you people are using?
So the hydrogen peroxide is available as 3% hydrogen peroxide. It has to be freshly prepared. It comes in a brown bottle or a white bottle. So whenever we use it, the bottle should be sealed. If somebody has left it open, because it comes in a 100 ml container, if somebody leaves it open, it becomes water. That's useless. So it has to be a fresh bottle, and you inject about 10 to 20 cc of hydrogen peroxide inside the cavity through the nasocystic tube. Are you talking about the nasocystic irrigation, right?
Yes, sir. Yes, sir.
So Hydrogen peroxide works by releasing the oxygen-free radicals, which are released in the initial 5 or 10 minutes only. After that, it becomes water. So in the ward, the patient has a nasocystic tube inside. We open a freshly prepared bottle, which a fresh bottle of hydrogen peroxide, loaded with in the syringe of 20 cc, and inject through the NCT and leave it for 10 to 15 minutes. Don't mix with saline, don't mix with water, just leave it like that. After 15 minutes, when it's had in this oxygen-free radical job is over, then you connect with a 100 ml of saline bottle and let it go uh, uh, in a flushed manner or a fast manner. It should not be other way around. It should not be hydrogen peroxide after saline, because then it gets diluted there. Okay. The only caveat is that some patients get a lot of pain while hydrogen peroxide is given. If that happens, I don't use it, because that tells us that there is some leakage in the wall of the collection, which is going to the peritoneum, and some peritonism happens. So if the patient says I get pain, I will only use saline as my irrigation fluid and not hydrogen peroxide.
Many patients do complain of vomiting, sir, after injecting hydrogen peroxide.
That's right. That's another symptom. Correct. You're right.
Dr. Viral and Dr. Sameer, there are a few questions in the chat box. I think you can ask relevant questions which are relevant for today's topic.
Actually, I want to ask one question, sir. How do you manage enteral nutrition in the peri-procedural period? And another thing, after once the collection has resolved and we remove enteral whatever stems or whatever we have put, after that, when you will start the patient orally?
Good question again. So most patients start feeling better once you have drained them, if the indication is good. Just the mere presence of collection is not the indication. They should have symptoms. So those symptoms would start improving and they will start eating. But if they're not eating still because of either continuing infection or new infection which has come into a sterile wound, then we prefer to place a nasojejunal tube, because that would help in giving more gut nutrition, which is prevents the sepsis, improves the overall symptom situation. We don't try to use a nasogastric tube, because this feed will now go inside the cavity. So that's the reason of using a nasojejunal tube for the feeding purpose.
So, sir, do you recommend in all WOPN we should put a nasojejunal tube?
Not all. So those who have a good albumin and are eating well, they don't require it. Those who have a poor albumin, then we place them at the same index procedure itself, because we anticipate that they will not be eating and they will not recover faster. So so we avoid one extra endoscopic procedure. Same time, once you have drained, you place a wire guide down, and place a nasojejunal tube with the same sitting.
So in one of your slides, you showed that when we puncture through the esophagus, so should we place stent or we should leave it? Metal stent is out of question, no, sir, from this, yeah. But plastic stents we can place or not?
We can place plastic stents. So a trick over here is never be in a hurry to drain. You spend at least 5 to 10 minutes before drainage, and this time should be spent not only in interrogating the cyst, you should also look at which is the right position for me to puncture, enter the cyst. And so you look at the G junction through the EOS scope, an endoscopic view, you know where the G junction is located. And keep it in mind, you can spell it out that 40 centimeters G junction. Now, if you forget also, at least your assistant would remember that you have told that 40 centimeters. And then your needle has to be at least 40 centimeters beyond. Your puncture point should be beyond that. Otherwise, if you have accidentally pulled back and punctured, then you cannot do entire thing. And those collections which have both access from the stomach as well as esophagus, it is better to drain from the stomach side, because the gravity helps in draining, and that's a much safer way to drain. But if no other way is available and esophagus is the only way, then use a small caliber balloon and place a plastic stent.
Dr. Viral, can you please ask few questions from the chat box?
Yeah, sir, one of the person has asked, how will you treat this percutaneous fistula? Is there any role of endoscopic drainage after percutaneous fistula?
Yeah, those are very difficult ball games, Viral. The longer it is between the index drainage and the patient coming back with a fistula, the more likelihood that that patient has got a disconnected pancreatic duct. That means the head and the tail of the pancreas are not disconnected. It's a viable pancreas secreting all the pancreatic juice and sugar and insulin, but it's not able to drain it out and it's coming percutaneously. So there are few ways to tackle it endoscopically, which may or may not succeed. The conventional teaching is that you do surgery and you remove that part of pancreas, but we need to salvage it. We need to use that pancreas for both digestion as well as prevention of diabetes. So one of the ways that we follow is that do an EUS. First is get an MRCP and show how much is the gap between the head and the tail part. If the gap is very short, then we should try to bridge first by the ERCP route. If we are able to cross that disconnected segment, which looks disconnected on MRCP, but this is not a dynamic investigation. Secretin MRCP is a more dynamic investigation, but unfortunately it's not available. So ERCP is the next best way. So gently, if you inject contrast and are able to fill upstream towards the tail side, then we should try to bridge the two by transpapillary stenting. But frankly speaking, this process works in about 10% or so. 90% it doesn't work because now that part has gone, it's atrophied central part and upstream is separate. So in this situation, now you either block the percutaneous tube depending on how much drain output is coming. Say somebody is draining 100 ml per day and the mileage of that fluid is say 10,000 or 1 lakh, which confirms that it is a pure pancreatic juice. Once you block it, this fluid will start accumulating inside. It may not form a pseudocyst purely, but it may cause some kind of a fuzzy collection. And this should be done as an inpatient. So do an ultrasound percutaneously. If you find a small collection, if you're able to see it, do an EUS and drain and make a plastic stent and leave it permanently. Then you can safely remove it. This would work in 1 out of 4. So 10% and 1 out of 4. So now you're left with about 65% patients now, which is again a difficult job. So now you see if the PD is still dilated and a long segment of the PD upstream is dilated, then you can use an EUS guided drainage where you can puncture either from the disconnected upstream or from the tail side, whichever is more easily accessible from the EUS, and try to place a plastic stent, which will again succeed in 1 out of 4. So we can do a good job, but it is not very foolproof method.
So there is one of the questions: should we lavage WOPN with antibiotics? I think earlier there were few papers which used to advise injection of amino
It doesn't work. I'm sure all of you agree with it. It doesn't work because systemic antibiotics are better, and installation of gentamicin or something inside doesn't really work.
Sir, is there any role of ERCP with PD stenting, like what we do in CP with pseudocyst? Like in WN, almost 2/3 of the patient are having a disconnected duct. So is there any role of planning ERCP plus PD stenting at the same sitting?
Same session of drainage.
Yes, sir.
Too early. Kunal, when we drain, the entire collection doesn't come out. Entire fluid doesn't come out. It's in a high pressure area, but once you put a stent, it will decompress to some level, and then rest of the part actually happens very slowly over a period of few days or few weeks time. So doing an ERCP at that time may not be very useful. You can in fact cause infection which was not there to start off with.
Previously,
so,
yes.
That philosophy, I don't, although there are publications of that in GI endoscopy many years ago, but I don't agree to that way of handling. But we should do an ERCP very early after the complete resolution of cyst. So if you have drained today, 2 weeks later, if you see that the cyst is totally gone, at that time get an MRCP, and at the time of stent removal, metal stent if you have placed, at the time of stent removal, do a PD-gram, do a ERCP, but this should not be very aggressive pancreatogram. So this is our observation, that if you do early ERCP, say 2 weeks later, sometimes the disconnection is not permanent. It's still a leak, but not scarred enough. And that is the crucial window of opportunity where we can do a transpapillary bridging.
So, Dr. Viral, would you like to ask anything further to Sir, Dr. Samir? So, with everybody's permission, can we give a vote of thanks, all faculties?
Yes, sir.
Yes.
So, sir, thank you so much, Dr. Sandeep. And on befolded hands, I thank you from Ahmedabad Physician Association and Noble Gastro Hospital that you accepted our invitation. And this was for the first time. We hear you always in conferences, but this was an honor for physicians and surgeons of Gujarat that they could listen to you today. And thank you so much, sir. Thank you. And I apologize, I'm late slightly. Sorry.
Thank you, Yogesh. Thank you, Viral, Kunal, and Samir. Thank you very much.
Thank you.
Thank you, sir.
Thank you.
Thank you, sir.
Good night.